Thanks for joining us, Dr. Lenguth. Today we're discussing what to ask your doctor. So I've got some initial questions I want to ask you. With an initial diagnosis of a chronic illness, is it normal to feel anxious, upset, nervous?
Certainly. I mean, pretty much everyone who goes along and receives, not specifically about vasculitis, but any diagnosis which could affect your quality of life, and particularly diseases which can last, in some cases, forever. You do experience a loss, and really you go through perhaps the 7 stages of grief. It's not unusual to feel quite angry, usually because these diseases don't occur for a reason. They don't occur because you've lived bad habits. They don't occur generally because you've got a genetic risk. You can't really promote them that much from poor lifestyle, although probably that does contribute to some forms of vasculitis. So it's not unusual to really feel quite upset. The other things with it is that because we initially treat vasculitis with steroids still a lot of the time, though hopefully those days in the next 10 years will come to an end, steroids have profound neuropsychological effects. There are very few people who don't or aren't affected by these medications. And it's really important to know that in the initial stages, people can have close to mania and occasionally actually acute psychoses-like events. That doesn't happen very often, luckily, but it certainly can. It's not great for people with pre-existing mental illness who may suffer far more. And I think it's really important to know that when you feel weird on oral steroids like prednisone or prednisolone, that's pretty normal to feel weird. And in fact, not many people enjoy being on steroids. In fact, I would say almost no people enjoy being on steroids. So, initially when you go to a consultation, and if that consultation is as an outpatient, I guess it's a bit different if you're very sick and in hospital. You've generally worked out already that you're very sick. But you're receiving a diagnosis which is potentially scary. Most people would never have heard of vasculitis. It's not in people's general lexicon or understanding, and so it can be very fearful. I always think it's important to take a support person, a spouse, a significant other, anyone who can help you understand, because probably you've got a lot of questions. You're going to receive a lot of information in, let's say, 45 minutes to an hour. And we do know that the most you can remember of a consultation like that from lots of data done a long time ago is perhaps about 60 to 70%. And you may not remember the important parts. And often I find when patients come a second time, we're going through questions again which have been answered the first time. So I think it's important to, one, write things down. It depends on the doctor, but if patients ask me, can they record the session, I always say that's fine. I've got no issues with that, but I think it is important that you do ask your doctor. Note-taking is certainly well accepted, and hopefully when you leave, you receive some form of information that can help you consolidate what you've learned during that time. But it is useful to have a resource person, whoever that is, because they can help you shoulder the load or the burden of this new diagnosis, which, as you said, is going to be worrisome to some degree, at least in most people. It really does depend on your pre-existing personality. Some patients take bad news incredibly well. In fact, so well that we wonder whether they've understood it. But some people are just naturally good at coping with various things. Others aren't. And so you need help to get through that.
Yeah, I think that's a good point that you raised, particularly in regards to having a support person there. So, and as you said as well, there's probably a lot of questions to be asked by the patient. So what sort of questions do you think should be asked or could be asked by a patient to their specialist?
I mean, I guess you want to know what the diagnosis is. Often we're giving people, the disease names are long, eosinophilic granulomatosis with polyangiitis is not something that most patients suddenly go, oh yeah, I can say that to my friends. But it's a few times where we often think abbreviations, which you teach your patients. So EGPA, at least they can remember that. It's hard enough, but you should definitely know what the diagnosis is. Is it going to last forever, or is this potentially a short-term thing? And what it's going to mean for your life going forward. Now, it can be very difficult, and often is, because diseases change their behaviour over time. Some types of vasculitis have a good chance of being a one-off illness, or what we call a monophasic illness. So giant cell arteritis certainly can be one-off. It can still cause significant disease, and the treatment occasionally can cause significant problems. But there's a chance that disease goes away and never comes back. Other diseases, like GPA, granulomatosis with polyangiitis, is almost universally a relapsing disorder. In fact, I would hesitate to say that it was ever not a relapsing disorder. Microscopic polyarteritis is mostly not a relapsing disorder, which is good, but people can suffer significant problems. So I think it's important to understand, how am I going to deal with this? We don't want to overburden you in that first meeting with bad information, i.e. information which makes you feel bad about the rest of your life. But we want to give you a realistic expectation of what to expect. To some extent, that's something that you're going to get an appreciation of in the, let's say, first 6 months of the illness. You don't want to overwhelm your patient with information or make them feel, as I said, too bad about the diagnosis, because making people depressed about their diagnosis or feel bad about trying to help themselves doesn't help them get better. We want to be realistic, but we don't want to be all doom and gloom. Neither do we want to pretend that the illness is not serious. And I think the important thing is simple things at the start. What medications do I need to take, and how am I going to take them to get better? What should I not do? Will this affect my work, or how will it affect my work? Because we need to know what you do. Driving on high-dose steroids can be somewhat problematic. There may be rules about your workplace that doctors may not immediately know. And so that might not come to you then, but you should be able to contact your doctor to ask about those things. I know if you have diabetes and you go on steroids for your vasculitis, often we need to put you on insulin, and that complicates certain activities like heavy goods driving, etc., being a pilot. So there are lots of potential complications.
So in regards to the treatment options then, I know that a lot of patients are concerned about, particularly initially with the use of chemotherapeutic drugs, such as cyclophosphamide and the like. So is it something that patients should be aware of as well, that the side effects associated with those type of drugs?
Oh, definitely. I mean, it's been shown that patients are more accepting of treatment and have a more realistic appraisal of the chance of side effects. Because often when we say the word side effect, people expect that they're going to get it. When in fact it's only usually a minority of patients. Often I find giving printed information for the patient to read about. If there's pretty much no choice, i.e. this is the best treatment, then which has clearly been demonstrated in studies, and we have now a lot of vasculitis studies which inform us of the best choice, then I think going briefly over those side effects, noting the more serious ones, but then giving the patient either printed information or, as I do generally, online, giving the patient time to read about that, and at the next interview, then talking more through any worries or concerns about that. The term chemotherapy is interesting because, in fact, corticosteroids work by being a chemotherapeutic drug. Pretty much everything's chemotherapeutic if you use enough of it. And so all of the drugs can be considered like that. And I try not to use that term because people's instant reaction when they hear chemotherapy is nausea and vomiting and your hair falling out. And that's the kind of media representation that you learned off TV, people with no hair who are dreadfully unwell. And with our modern medications, we can either block that, or the drugs we use don't cause it. And so very few people suffer any of those reactions that are severe, largely because we've modified the doses we use, and it just is relatively uncommon. It's nowhere near the frequency people get worried about. And I think reassuring patients about modern medications, I mean, especially, say, the use of tocilizumab for giant cell arteritis, or the use of rituximab. So rituximab is a chemotherapy. It kills B cells. And most patients, when I've asked, I always ask them, did you believe me when I said you were going to feel well after the infusion? I think about maybe 1 in 50 people feel some nausea, and that's probably just anticipation, worry. The drug doesn't have any specific effects that can lead to nausea. Most of them say, oh, I kind of believed you, but I still thought I'd get sick. So I think it's useful to be reassuring that these are novel drugs that work in specific ways. And yes, we still do use cyclophosphamide, and it certainly can cause nausea, but we use preventative medication to block that. And it's very rare nowadays that I would see someone with disabling nausea or vomiting, even from cyclophosphamide, because we can use agents that block it.
Yeah, that's fascinating. So it sounds as though the treatment options have improved. And I guess this leads into my next question as well. I know a lot of patients ask about the prognosis of their disease. Have there been any advances in terms of the prognosis outlook for patients with these autoimmune conditions?
I think the biggest advances in prognosis will be when we get rid of corticosteroids from the armamentarium. We know that if you look at severe vasculitis that affects your kidneys and or lung, that in fact it's the steroids that give you the increased risk of shortening your life in the first year. We know that if you have kidney failure, there's a bigger increase in risk of infection, and it's from the corticosteroids. And we are getting closer to being able to not use them with some studies more recently. But in most vasculitic treatments, we still need to use corticosteroids. They are necessary because otherwise your disease won't go away, but they come with a lot of side effects, and infection being the principal one. Looking at patients and looking at what everyone wants to know, will this shorten my life? It's actually a really difficult question to answer because we haven't had good long-term databases on vasculitis. We know that and largely we look at how did the vasculitis affect you. So if it's caused kidney failure and you're on dialysis, well then your attendant risks are that on dialysis your life is, by average, considerably reduced. So it really depends how it's affected you. And if you look at other inflammatory disorders that aren't controlled well, then on average they do increase the risk for things like heart attack and stroke long term. So if you look at rheumatoid arthritis, a different disease because it's always active if you're not on treatment, that increases the secondary risk of different types of vascular inflammation, much like if you became a smoker does. Now that probably does hold true in vasculitis. So there is good suggestion that we need to attend to other risks, so that exercise, weight management, looking at cholesterol, looking at risks for type 2 diabetes are important, not in the short-term treatment of vasculitis, but in the long-term maximising a person's health. So it's a very long-winded way to say a lot of the time we just don't know how your life is going to be affected. You know, but the older you are and the more steroid you receive, the greater the risk of toxicity.
Okay. And I think another big question that a lot of patients ask are what type of tests are used to aid in the diagnosis of some of these autoimmune conditions?
Sure. So some of the tests are very simple, and the most obvious test is giving your history to your doctor. And so patients always get an idea that all of our diagnoses comes through blood tests or scans, when in fact what we're really doing is confirming or denying diagnoses doing that, and that talking to your doctor, telling them what's the most important things. And I always tell patients you should concentrate on the things that have changed, or things that you now can't do or have had to change the way you do it. So those are the important things to tell your doctor. But with there are blood tests, obviously, for the ANZVASC-associated vasculitides, are critical to the diagnosis. We look at blood and urine tests, particularly to see if the vasculitis has involved your kidneys. And then there are various scans we can do, from a simple chest x-ray to CT scanning of your lungs and or abdomen, sometimes ultrasound, but it's not that useful really in looking at vasculitis. That can be in giant cell arteritis. We can look for features of giant cell arteritis in the temporal arteries. And then more expensive scanning, but perhaps really an Australian-led use, is the use of PET scanning, which is the injection of a sugar which goes to areas in your body of activity. And that has particular application in the use in giant cell arteritis, but it also has applications in other forms of vasculitis as well. So it's able to look for hidden areas of inflammation that may be asymptomatic, but may help the doctor a great deal in the diagnosis.
Okay.
It's also used and we use scans obviously to show that things have improved. In say granulomatosis with polyangiitis, GPA, lung signs can be remarkably quiet. You can see people who have no visible chest symptoms at all. You ask them about cough and breathlessness, they feel fine. You scan their chest and you can see all sorts of sometimes quite significant disease. And it's important to know that, because you want to make sure it gets better, and you want to make sure that you know what their lungs look like when you think the rest of them is better. So you can try and detect in the future a change for good or bad.
Okay, so what other questions or assistance can your specialists recommend to your patients?
I think, support groups have their role. So there are now many patient support groups. Some patients like them and some patients don't. But I think you should be given the option, and where there are support groups, you should have them available. So luckily, through our Vasculitis Society, we have some that are linked with us. We have lots of patient information. I think you should be given as much information as possible. We do know, however, from some fairly good studies, that patients who become too enmeshed in their diagnosis, in other words, people who spend a lot of time looking up disease or looking about treatments, the risk is they actually become more anxious. And so there's very good data in some chronic inflammatory disorders that patients kind of, in a way, become disabled by fear and anxiety. And instead of being a person in society who happens to have a disease, they kind of live the disease, which I don't think is healthy, and certainly from my point of view is not a great way to live your life. The whole idea of medicine is that we try and turn you back into a normal person who happens to have an illness, and that we should let that illness not affect your life as much as possible.
Yeah, it sounds as though having a good relationship with your doctor and your specialist is quite important. Yep. throughout the
Definitely. Over time, your doctor will get to know you and what you like, what you're likely to kind of underrate and what you're likely perhaps overrate. Each patient does different things. Some people put on a brave face. It's not that useful to your doctor to pretend or to say that you're not affected. Nevertheless, I don't think being told that makes any difference, because some people, that's just part of their personality. I think it is important to note down a few points when you go along to the doctor if you think you're not going to remember them. And pretty much I think it's useful to do that every time. Because if you've got some significant things to say, forgetting it at the doctor's is not uncommon. So if you think of the things that you want to tell your doctor, and there's no problem, don't give them a 20-page list. That will not help. But do write a few points for yourself so that you actually get there and you get through the questions that you want to know. And even if those questions aren't particularly about your disease, but you want to know them, well, that's your chance. I think it's important to be as honest as you can. Doctors, we hopefully no longer get upset when patients do the wrong thing. Most doctors have been patients in their life as well, and they know that humans are all very imperfect. None of us do exactly what we're told all the time, well, very few of us. And so it's okay that you missed medication. It's just not okay that you miss it all the time. It might be okay that you missed a blood test. Don't feel bad. No one loves having blood tests. But at the same time, we should be giving you a reason why you're having these tests. Some of them, as we've alluded to, are to try and monitor your treatment, but a lot are looking to make sure that we're not doing any harm by medications or other things. I think it's important to let your doctor know if you're using alternative healthcare products. Some will have definite interactions. So, for instance, St John's Wort has interactions with many medications. There are some products that we have no idea about, and the chemist won't have any idea about either, because there just is no data. Unfortunately, a lot of products are not regulated if they're sold, registered under the TGA as natural health products. We can't tell you. So it's a guess, but it's still important to tell your doctor that you're trying something. Even if we think it's not likely to help, it's important, if you want to take it, well, that's fine, but we need to be able to give you some advice on, is it likely to be safe?
Well, thanks very much, Dr. Damon Langooth, for your input and insight today. I think it's highlighted a great number of interest from patients about, particularly about their initial diagnosis and what questions to ask their doctor. So I think you've provided some great insight today. Thank you for your time.
Thanks, mate. Thank you.